venous thrombus, aortic dissection. Those are exciting as well. Thromboembolism. Anybody know what that is? What's a thrombus?
Collision thing.
I like your description of it. Yeah, it's a thing that's in there. Yeah, so it's basically just a blood clot. Thrombus is a blood clot. So and an emboli is what? It's like foreign. So it's generally like a clot from somewhere else in the body, basically, is a way to think of it. So like when people get PE, I knew that's where you were going with it. Like people get PEs from sitting on an airplane after surgery, stuff like that for a long time. They can have these thromboemboli. So that can cause a heart attack as well, or stroke, whichever it decides it wants to do. Yep, so you've got cardiac rhythm disturbances, which we're going to be hammering, and which is certainly a huge part of paramedicine. Infectious disease, endocarditis, pericarditis, and the many cardio. Can somebody say that word for me, please? Genital abnormalities. National EMS education standard competencies, shock and resuscitation, comprehensive. Integrates our knowledge of pathophysiology, which we're going to learn and get in depth. Management of shock, respiratory failure, arrest, emphasis on, obviously on preventing cardiac arrest by identification. All right. So our role. Do you have a question there, man?
Oh, me not.
Or you're just kind of
Yeah, I just.
your thing?
Yeah.
Don't spill your coffee again, man, all right? Yeah. So our role as paramedics, as A's that are already working as A's, is to be able to, use EKGs, 12 lead EKGs, and hopefully identify a myocardial infarction, and hopefully identify ischemia before it even gets to that point. So acute MI, sudden narrowing or complete occlusion of a coronary artery. Can anybody tell me the names of the coronary arteries? You guys did A and B, right? Somebody did mine.
Left lateral descending.
Left.
Anterior.
You do it way out.
Yeah, no, that was good. That's all right.
I'm trying to
At
find
least you
the
took.
full-
Oh, wait a second. He's like. Circumflex. Yeah.
Right or left?
Yeah. So you got your left main.
See, I got that one without looking up.
Your left main, your right anterior descending, and your circumflex, and then you have branches off of that, obviously. But so one person has an acute MI in the United States about every 40 seconds. I bet that's probably even more than that now because people are fat. Cardiac arrest is this cessation of mechanical activity. Right. So cardiac arrest, somebody who's in VFib or VTAC without a pulse. They don't have any mechanical activity, obviously, aka they have no pulse or not enough blood pressure to generate a pulse, meaning they're cardiac arrest. So, treat about 60% of out-of-hospital cardiac arrests each year. Has anybody ever heard the Seattle stuff there, where like, when I was there anyway, it was, because AEDs are so prevalent, they've worked really hard to get AEDs out to the public, teach CPR, public CPR, bystander CPR. So if you like have cardiac arrest in the city of Seattle, it's like a 60 or 70% success rate, save rate. Where like everywhere else, we're like 5, 10, unless it's witnessed, you know what I mean, by somebody who has some training. And then I think another big one is like Vegas. If you have a cardiac arrest inside of a casino, you have like a 92% chance of survival. Versus outside on the sidewalk, it drops to like 35 or 40.
Because they require that the security guards know CPR.
Yeah, and they have AEDs everywhere. So sudden cardiac arrest, generally is some sort of a rhythm disturbance, and if you can shock them quickly, you can get them right out of that. Which is why that whole cardiac pump. I don't know if you guys have ever seen anybody do that. I certainly, when I was a new basic, saw it a lot because they used to do it a lot. And I was always like, geez, he's already dead. What are you doing? But I actually saw somebody get a pulse back or a rhythm back with that, so it was cool. So I do it all the time. Yeah, yeah. Yeah. Well, I mean, basically, what you're doing is you're doing the same thing as essentially a defib. You're giving them a manual defibrillation essentially without, a non-electrical induced defibrillation. It's just like the kids who get bumped in the chest and go into cardiac arrest. They're right, they're hit at the exact wrong time, so it's kind of the opposite thing, but, what? Did it hit the chest?
And they brought that
You
back.
can, if good CPR is done and,
Straight in the chest.
immediately, for sure, yeah.
Yeah, there was a ER nurse that like knew what happened. He was like,
All right, so cardiovascular system, yeah, we got some blood vessels, delivers oxygenated blood and nutrients to cells. What's a specific nutrient that our heart really likes and needs a lot of?
Potassium.
Yeah. Even more so?
Calcium.
Yeah, calcium. You're just gonna keep,
I was just gonna go
you're gonna
to the
throw 'em out.
table.
So calcium's a big one. So like any post cardiac arrest, like a patient that has ROSC, that is return of spontaneous circulation, is almost always gonna be calcium depleted or deficient. So I always just give an AM, but that's not necessarily protocol. Delivers chemical messengers, hormones, yeah. And it transports waste, right, via kind of indirectly. All right, so this is the heart, and all its glory. So, do we have any questions about the structure of the heart, where the blood comes in through, comes into the right atrium, right? And it passively drops down into the right ventricle. When does it do that? When does blood enter the vasculature? Right. Wasn't really a trick question. I'm just trying to get you guys to wake up a little bit this Monday.
I'm awake.
You are?
Yeah, we're just to the EMS testing, so the
Yeah.
whole trick question thing is still.
No, I'm not. No more trick questions. Not today. Yeah. So this is, obviously the left ventricle, which is what a lot of people focus on. That's where you get a lot of the, thickening of the muscle over time. The left ventricle, you get, whether it's kind of left-sided, heart failure that turns into right. Your right ventricle is generally, when people have right-sided heart failure, that's generally where you see what, like a
Pedal edema.
right, so pedal edema, versus if you had kind of left-sided heart failure, what would you have for a sign? Yeah, exactly, good, nice. So generally, like your right ventricle or your right-sided heart failure is your chronic heart failure patients. And then you can get kind of these acute episodes, whether it be an ST elevation MI that causes that left side to also fail, and that's when you get that, kind of flash pulmonary edema. Or maybe we induced it because we gave, the wrong medication. We gave albuterol to the person who already had pulmonary edema and caused them to go into flash pulmonary edema. I've done that before. So right atrium receives blood flow, blood low in oxygen rather, from the superior vena cava, inferior vena cava, and the coronary sinus. So just going back here, let's see if it's got a picture of the, doesn't really have the coronary sinus in there, but I can't remember. We'll see if we have another picture, but left atrium receives oxygenated blood from the lungs via the right and left pulmonary veins. And certainly the pulmonary veins, people get screwed up with, so why are they called pulmonary veins? Right. Versus, so that is something, every time I come over here and do that. Nice. It's something that definitely people get kind of confused. So your right ventricle pumps deoxygenated blood to the lungs. The left ventricle, pumps it throughout the rest of the body. I think it means the septum, but this says the septa. Separate the heart into two functional pumps. Right heart, the right atrium, right ventricle, which is a low pressure system, your pulmonary circulation, and your left heart, left atrium and left ventricle, which is obviously the high pressure system, pumping out to your systemic circulation. Everybody understand that, all right? So myocardium, again, it's your middle layer of your heart. That's basically where your muscle, the thick tissue muscle is responsible for most of the contractility of the heart. And ejection fraction, how is that? Do you know how that's calculated?
I did back in chapter.
Right, so I mean, it's,
The percentage of, like, what's basically left in the left ventricle after, like, what the volume
uses
that goes
that.
out versus what was in there.
yeah, so I mean, it's, what is it indicative of, overall? Like, something that we use more often, so we don't really use ejection fraction, right? Because it's a calculated number that they usually get with an echo, and that's generally how they figure out ejection fraction. But what would we compare it to that we could calculate?
Map.
Sure, MAP actually would be a good one, but I was thinking kind of cardiac output, you know, which is what? How do we do that?
Heart rate times.
Stroke volume.
Stroke volume,
Right,
yeah,
which would be, you know, using your MAP at that point, so. Good. Yeah. So your coronary arteries, the left main coronary artery supplies the left ventricle. And these things are kind of tough. You gotta kind of memorize this stuff as you're going through the cardiac section is, you know, certainly knowing, while you're looking at EKGs, the area of the heart that's affected, but even more important is knowing the vessels that could be blocked, or be the problem to cause that. And that's something I still at times struggle with because there's differences between people as well, and you'll see that as we go. So coronary arteries, left ventricle, intraventricular septum, that's essentially your left main supplies the left ventricle. So that's fairly easy. The right coronary artery, RCA, is the right atrium, the right ventricle, part of the left ventricle, and portions of the conduction system. And hopefully it's got a picture here, good. So again, I'm gonna come over here because, all right, so there's your right atrium right there, and right there for you peeps on that side. So you've got the vessel right there, right? What is this vessel? Did it kind of say it on that picture?
Right coronary artery.
It is, correct. I mean, I guess there's no real. So again, that's supplying your right atrium, your right ventricle, and part of your left ventricle. But more importantly, a lot of the time, it's going to affect your electrical conduction system. And so how would we know if somebody had a blockage, let's say, of that right coronary artery? What might we see?
Reduced blood pressure.
Pulmonary edema.
Could be reduced blood pressure via
The,
slow heart. So if like your SA node's taken out because it's supplying blood to your electrical conduction system, you get a bradycardia generally. And a lot of times that's how you can tell. Obviously you're gonna look at the 12 lead as well and you're gonna use that, but that's kind of where I was going with that. Cardiac cells have 4 properties. So automaticity, excitability, conductivity, and contractility. So you were kind of asking about, you know, dopaminergic. So let's see, what would be, so have you guys discussed kind of chronotropic effects? I'm sure you have with some of your meds specifically, right? I know you've got potentially a drug quiz today that might utilize some of this terminology. But chronotropy is what? Right, so that's kind of, whether it be your automaticity, you know, so your SA node or your AP node have a set rate, or kind of your excitability. What is dromotropy? We talked about that or not? Right, so that would be your contractility. I don't know if you heard that, but dromotropy is basically your contractility of the heart. So like dopamine, for instance, is a good drug. At what dose does it start to do that? Huh?
What's that drama?
Nah, that's dromo.
10 to 20. No, just kidding.
5 to
5 to 10.
10.
Or that's dopaminergic is your
Yeah,
5, is your 2 to 5.
5.
What did you say, 10 to 20?
5 to 10.
5 to 10.
Is
That's
it
more
beta?
chrono, that's more rate.
Or if you
more-
want
So
alpha,
alpha would
10
be
to 20.
Yeah.
So alpha.
So it's alpha, and it's alpha for your vessels, but it's also for some of that contractility.
Oh, so-
That being said, there's a better medication for more contractility specific, which is dobutamine, but you're not getting good on that. So, but again, I just wanted to relate those things a little bit to that at least. So,
Comments on that?
conduction system comprised of 6 parts, so your SA node, your AV, the bundle of keys, the right and left bundle branches, and the Purkinje fibers. So does anybody know what the set rates of any of these are?
60 to 100.
Yes, depending on what you read, yeah.
The AV nodes, 60 to 80. 40 to 60.
40 to 60, yeah, that one's definitely 40 to 60 DAV.
Yeah, Purkinje fibers are what, 20 to 40?
Like less than 40 basically. So if you have a heart rate less than 40, unless it's like Lance Armstrong or like an extreme runner, generally you can assume that the blockage is far enough down where it's affecting that. But that's just a side note there. We'll probably get into it here. Nerve stimulation. Stimulation strengthens the force of contraction, increases the heart rate. So essentially that's just talking about, how much stimulation is sent from the SA and the AV, or how much the AV receives to then send further down. But overall, that's going to increase your heart rate. And so so stimulation of the parasympathetic nerves. So, have you guys talked about atropine yet?
Yeah.
Okay, so what's that?
Parasympathetic.
What's that?
Parasympathetic.
Okay, so what's that mean?
It means it works against parasympathetic nervous system,
Causing?
causing increased blood pressure, heart rate.
Heart rate specifically, yeah. Hopefully blood pressure too, if they're hypertensive, but specifically heart rate. So here, your parasympathetic nerves, when they're stimulated, slows the heart rate. And that's through slowing the discharge through the SA node. So essentially, by slowing the SA node, that in turn slows obviously the AV, because the AV doesn't get stimulated until the SA sends it a fucking message saying what's up, do your thing. So overall, that weakens the strength of atrial contraction, because that's your SA is in your atria. It's all the way to the top of the heart, essentially.
Can you repeat that last concept, Ian?
Which part?
The SA and the AV, like.
Basically just the SA has to send the signal to the AV. So the AV is not doing anything until it receives a signal from the SA.
But like, how is it that if someone's heart rate just resting was like 80, how is it that their AV knows to do
Well,
anything?
okay, so I should say, it's not gonna do anything more than what its intrinsic rate is. So the intrinsic rate, we said of the AV is what?
40
to 60.
Right, so essentially, if the SA was completely out because the blockage was high up
Yeah,
in the right coronary artery,
yeah.
okay? Then the AV would still function, but it wouldn't go any higher than 60.
Oh, okay.
You see what I'm saying? Unless you did something to either increase chronotropy a different way.
So it's not like your SA node is firing 60 to 100, while simultaneously your AV node is.
So your SA fires, it sends the signal down to the AV, which then fires. And the reason is why? And again, I guess we
Because
really need to
there's
see we really need to see a picture, kind of like a diagram of the actual nerve
Is
pathways.
it connected by his Purkinje or?
Jeez, yeah, no, so the Purkinje fibers are passed. Once we get to the picture, I'll make sure that we clarify that, but essentially your SA is essentially what squeezes the top of the heart,
Yeah.
okay? So if you think about it, there's a little bit of a delay from the SA to the AV purposefully for what, you think?
Allow your ventricles to fill?
Right, and that's that love dub, that the squeeze, the top of the heart squeezes, bottom of the heart squeezes after.
Yeah.
And that's a good way to kind of think of it is, so if you don't have an SA node, then you don't really have any atrial squeeze at all. It's just passively filling into the left and right ventricle, right? Which is okay to some degree because there's passive filling in the ventricles anyway. But that little atrial kick is what they call it, is important, and ultimately, depending on how healthy the person is, it will affect their blood pressure and overall condition pretty quickly. All right, so I think we were there and there. So the primary assessment, A, B, C, D, E, sure, yep. You wanna be, you wanna have an airway, you wanna be breathing. Yeah, you'd like to have a pulse. Hopefully you're not disabled. And hopefully you don't need to be too exposed, but we need to expose some. If the patient is unresponsive, then right, so we all know this, we're gonna switch it up, C, A, B. And yeah, he's still in there, but not so much worried about the D at that point, but that's all right. Might wanna just keep that acronym, that's cool. Acute coronary syndromes.
Don't worry, you can stay.
D can always stay in there. You don't want it in there too long, anyway. But, coronary syndrome, sorry, a series of cardiac conditions caused by an abrupt reduction in blood flow through a coronary artery. Okay, so we talked about angina. A lot of people have what's considered stable angina or unstable angina. And I don't want to get too far ahead of myself like I did last time I did this lecture, which I feel like maybe I've already done to some degree, but we talked about what angina is. What do you think unstable versus stable angina be?
Stable goes away when you sit down and chill out.
Right? What about a person that needs to take a nitro to get relief? Would you consider that stable?
They have to take nitro?
Are they
I'd
prescribed?
say it's unstable.
Hopefully they're prescribed.
Well, then,
I would say unstable as well. The book definition is a little gray area with that, but I agree. I think unstable, I think stable angina is, okay, I walk, I'm an old dude, I'm walking, a little chest pain, I take a break for a minute, it goes away. Versus I gotta take a pill or something else, I would put that into the more unstable. But eventually, unstable angina, if not treated, or any angina, if not treated, can turn into whether it be a non-ST segment elevation myocardial infarction or an ST segment elevation myocardial infarction. We'll talk about the differences between these two. But essentially the big thing is the infarction. Doesn't really matter which one it is. Infarction means death, muscle death. So you're right, so sometimes it's chest pain, or a lot of the times it's chest pain, but it's not always chest pain. What have you guys seen for whether there's ST elevation MIs or non-ST elevation is irrelevant, but what have you seen for people that were having a heart attack and
Left shoulder.
had really strange complaints?
Back pain.
Certainly jaw. Did they have with it?
No, they do not.
Okay.
Left shoulder, no chest pain.
Jaw pain, shoulder, yeah, anything else?
Back.
Yeah, where do you see that?
Females.
Yeah, that's weird, man. No, I've also had I've had diabetics that have been like, yeah, just my left big toe hurts. And you're like, fucking hey, man. It's 2 in the morning, okay, and you just throw them on a 4-lead and you're like, what the hell? With 12 you realize you're having a huge MI because they just don't feel, their nervous system, it doesn't work like ours. It's, worn out and, long-term diabetes does major damage. So you get chest pain a lot of the time, you get shortness of breath, but a lot of times you don't, and you just gotta really use your detective skills to figure it out, or just throw everybody on 4-lead for the most part. But so OPQRST, so obviously, yeah, when did it start? What makes it worse? And I do think that OPQRST for chest pain in particular is probably the biggest time to use this, I think. I mean, obviously onset for a stroke I think is important as well, but strokes don't generally radiate. Things don't usually make it worse unless it's like light. So I think OPQRST is definitely good for any chest pain, for sure. So yeah, so when did it start? What makes it worse? I don't know what palliation means. What's that?
They make it better.
All right, thank you, okay. Quality, so quality, I don't know, quality.
Thumbs up.
I usually give me a word, right? Is it sharp? Is it, because you had mentioned back pain, which certainly back pain you can get with an MI patient for sure. What else can you get back pain for medically? Yeah, intense gallbladder as well. Yeah, and I was gonna say dissecting aneurysm. you get that, stabbing back pain. Those like freak me out. When you hear like stabbing back pain, that's scary, especially if they're starting to become hypotensive. But also, you can have a dissecting aneurysm, and where are your coronary sinuses? Anybody know?
The heart.
They are not actually, but good guess though. I mean, right next to. Nope, so they're basically at the top. I wish I could go like directly back to the picture, but let's see. No, it's not the green one. So essentially they're right at the root of the aorta. So where the aorta attaches, basically the top left of your heart. I mean, anatomically the heart is actually twisted, but we'll just think of it like it's like a flat. Your coronary sinuses are right there, and that's what sends oxygenated blood to all those vessels that we briefly brushed over and supply oxygenated blood to the heart. So what's really wild is when you get, I'm going to try and do this, I really don't want to draw pictures, but I just feel like I didn't have it. All right, this is your heart. Isn't that amazing? So this is your right atrium, your right ventricle, left ventricle, left atrium. And you got your aorta coming out here. You've got your coronary sinuses right here. And I think somebody mentioned it. I know it's a really awesome picture, I know. But somebody mentioned, actually we were talking more about when does blood enter the heart, but when does blood enter the coronary sinuses as well?
I have to ask what it is.
Right, because if you think about it, this left ventricle is going to shoot the blood, it shoots it. What's that?
It catches the backflow, right?
Yeah, so it basically gets kind of the backflow as the heart relaxes, because if you think about it, the left ventricle is going to expand. It's going to shoot the blood up the aorta, around the aortic arch, which is important because this is where your cerebral arteries, the arteries that go up to your head. Hey, sweet. Okay. So a lot of times people who have long-standing hypertension, whether usually not controlled, they're really pumping a lot of blood out of their left ventricle, which causes thickening of that muscle that we talked about briefly. But it also causes blood to just be like hammering right here, essentially, all on this part of the arch. Because as the aorta goes around and then down to the rest of your body, this is generally where you start to get like a dissection. And this is the different layers of your vessel. Blood starts accumulating in there. But what it can do is it can dissect both ways. So you can have it start to split this way and split back this way. And then what do you think that causes?
Produce signs.
So you can have signs of an MI, essentially. So you can have ST elevation MI patient who has tearing back pain or stabbing back pain because they were having a dissection, but now their coronary sinuses are also dissected and or cutting off blood flow entirely through that little opening. And you can have somebody who has an ST elevation MI on a 12 lead that if you freaking treat, you will kill them. Again, I don't know that. But, so your history taking and your OPQRST is very important. You know what I mean? Like what started first? Back pain, or the chest pain, or the shortness of breath? You know what I mean? So again, I think that OPQRST is huge for this one. Sorry, guys. Yeah, and dyspnea is another chief complaint. So what do we usually see for like guys that are having chest pain? I'm not gonna say guys, but a lot of patients that have kind of chronic, maybe medical, do they call right away or do they wait a while before they call for chest pain? Right. So the whole timing thing on the chest pain is difficult because it's like, well, when did it start? Oh, I always have some chest pain. Okay. When did this chest pain? When did this different pain start? And I think that's important to try to determine. So, did your patient pass out? Sure. That's pretty important because we would want to know that for any cerebral vascular type thing, but also with this great drawing, you can again see that the blood flow to the brain is obviously relevant to the heart, but it goes up those cerebral arteries to the brain there. Any issue with the heart certainly is going to cause an issue with the brain. So it can cause them to pass out if they're not getting enough. Palpitations, who gets those when they drink too much coffee? Have you?
I went into SBT yesterday.
Yesterday?
Yeah, it's
Did
actually,
you-
yeah.
Did you like go to the bathroom and straighten it out?
What?
Bagel down?
I did bagel out, yeah.
You bageled out? Or you bageled yourself down?
Down.
You're like, I don't know. No, a lot of times people just like have somebody bear down.
Yeah, it's
Or go to the bathroom if they need to, and it fixes it. I've gone to people's houses that were in an SVT, and they're like, I'm not going anywhere before I use the bathroom, and I'm like, perfect. Use the bathroom, they come out, and they're fine.
Same here.
No, I mean, obviously, there's more to it than that, but, so you actually legit go into SVT where it won't self-correct?
Well, the first time, yeah.
The first time it did, or didn't?
The first time, I was in SBT for like probably 5 minutes, and I was on duty, and my shift partner was getting me adenosine out, and I managed to, on like the third try, I managed to make it down.
So have you talked to any cardiologist about this?
That's what I was on the phone for, yeah.
Today?
I have to. Yeah, just now.
Oh, great, man. Don't be drinking any more coffee.
I
I was trying to make jokes, and here we are.
I know, I
You
made it
I'm
all
like,
serious.
bringing up-
It's a pre-workout, he doesn't.
No,
work out
after
anymore.
the first time, which was like 2 months ago, I stopped drinking any caffeine at all.
Okay.
Can we actually just do it and learn from it?
Yeah, maybe, yeah. Can we just like,
It'll make
we
you force you to drink coffee.
probably should just like, yeah, put a halter monitor on you and just be like, as soon as you go into, just be like, all right, everybody,
Now, what do we do?
who's ready to learn?
What's our goal?
Here's our assessment.
I know.
So you never had to be electrically or chemically converted though?
Not yet.
Did you have any, just out of curiosity, history of heart stuff?
Yeah, my